Toolkit. My name is Alexandra Coombs, and I am a Program Officer on the AIDS-Free Project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 5 presentations followed by a discussion period during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It is great that we are able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. A few troubleshooting tips. If you lose connectivity or cannot hear, close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Use the Q&A box to ask AIDS-Free Tech for assistance. If the troubleshooting steps are not successful, please rest assured the webinar is being recorded and you will receive an email with a link to the recording following today's event. The recording will also be posted on the AIDS-Free website. Questions that do not get answered during the Q&A sessions will be compiled after the webinar, shared with presenters, and responses from presenters will be shared with participants and others via the AIDS-Free website. To get us started, I will now turn it over to our moderator, Helen Kornman.
Thank you, Alexandra. I would like to welcome and thank everyone for joining us today. My name is Helen Kornman, Technical Director on the AIDS-Free Project. The World Health Organization recommends Lopinavir-based regimens as the optimal first-line antiretroviral therapy for HIV-infected children 3 years of age or younger. The Lopinavir Pellet Toolkit is a new resource that provides clinical information for healthcare workers related to dosing and administration of the medications, as well as tools for healthcare workers to use when working with patients' caregivers. The toolkit also contains guidance for Ministry of Health staff and other stakeholders on health system considerations for planning, implementing, and managing national rollout of Lopinavir pellets. For today's webinar, organized by AIDS-Free, we have invited 5 speakers to help demonstrate the functionality of the toolkit and review the resources and tools in these 2 core sections, the healthcare worker section and the rollout planning and management section. Today's presenters will also discuss the broader context of Lopinavir pellets, from evaluating their effectiveness to the status of global rollout and lessons learned from in-country implementation. We also have Sharad Jain, Head of Sales.
Thank you very much, Helen. It's nice to meet everyone. And as Helen said, I will be discussing just briefly some background on the pellets, where we are to date, and some of the country experience
Q&A box for Gerard and for
and lessons learned thus far.
And please silence your phone and devices.
So as many of you are likely aware, the LPVR pellets that were approved in May of 2015 has provided the market with an alternative LPVR formulation from the liquids and the tablets. So some of the key benefits to the pellets for our youngest populations are that it is heat stable, which really eliminates many of the cold chain issues in supply and storage for our countries, as well as taste masking, which is an improvement over the very unpalatable Kylitra syrup that is the alternative in use. It also allows administration with either mixed into food or breast milk or other liquids. So there are different alternative methods to administration and really helps out for patients that are developmentally not able to yet swallow the tablets whole. So in the time since it's been approved, there's been widespread interest in pellets across countries. Many countries are interested in using it in their population, as well as performing pilots and to better understand the acceptability and feasibility. So it really has generated a lot of demand for this product, and really shows that there needs to be an alternative treatment to the syrup that's currently presenting challenges across countries in terms of use. So despite the widespread interest, it actually has meant that the pellet demand has exceeded the global production capacity that is current. So given this, the APWG, the ARV Procurement Working Group, has worked closely with CIPLA as well as other partners to design recommendations for countries, to inform them of the latest updates, to allow them to have questions about their scale-up plans and really have a dialogue about informing scale-up based on current capacity levels. They've also advised that that countries should maintain alternative formulations of LPVR in the current situation until the supply has stabilized. The great news is going forward, the future outlook is good. There's been a variation filing for the pellets themselves, which will help to relieve some of these supply restrictions. And then also the LPVR granules, which are a similar formulation, are upcoming and will help to also stabilize the market for this niche product. Likely it is 2019 before this meaningful increase in capacity happens. So in the meantime, the APWG is monitoring this, is providing recommendations and updates on a regular basis. So they're definitely a group to go to with questions on any sort of decisions around pellets and scale-up planning. So just to go through a few of their current recommendations for countries in lieu of in light of the supply restrictions. So right now, they are advising countries to plan for at least 6 to 8 months in lead time. So making sure that orders for the pellets are well in advance, and that there is a consideration of the possibility of using staggered deliveries. So that obviously takes a lot of planning and coordination, but something to help relieve the supply constraints. The next thing is order rationalization. So really looking at who is appropriate for patients to be put on pellets, and I'll go through that in more detail on the next slide. But this is really important, especially given the supply limitations, that there is rational quantification happening. There's also been the recommendation for those countries that have not yet started using the pellets, that there's a recommendation to defer this implementation and to continue using the liquid until the supply situation is stabilized. There's also just that, again, that I reiterated earlier, but just that the recommendation to ensure adequate coverage of LPVR formulations in country during the transition. So making sure that there's either the liquid or the tablets, if those are appropriate for the patient population, making sure that those are in the supply and the pipeline in country. So just want to speak to this a bit more. These have been the recommendations that have come out on how to adequately prioritize patients. We know that it's really important to determine the LPVR formulation based on age and weight band, but also the child's ability to swallow. And this is something that the clinician reassesses. The APWG has made a few recommendations on how to help guide countries in thinking through their prioritization of pellets and how to use that and implement that in the current environment and the current global capacity. So to start, the prioritized patients would really be those that are on LPVR-containing regimens who cannot tolerate the liquid but are yet unable to swallow the tablets whole. So it's really that middle population of patients that need that and that are newly initiating onto treatment. The next transition to pellets may be delayed and may have to be evaluated as things change, but those patients that are currently stable on nevirapine or efavirenz containing first-line regimens, or patients that are actually tolerating the liquid, the country may make the decision to maintain them on their existing regimens as long as they're stable in the meantime until the supply stabilizes. And then patients that should not be put on pellets are really those that are weighing over 10 kilograms and that are able to swallow the tablets whole. And then those children that are younger than 3 months and have that potential risk of choking and aren't yet able to swallow the tablets. So the graph or the chart here on the right really kind of describes the visual around who is appropriate age-wise and weight-wise for each Lopinavir product. So really we're looking at the Kylitra syrup for those younger than 3 months, and once they're able to swallow those pellets, they can be moved to the pellets for children under 3. It's important to note, though, that once children reach the 10 kilogram mark and are able to swallow tablets whole, that it actually is beneficial to switch them to the tablets simply because the pill burden for the pellets does get quite large as children grow in age. And then to close my portion of the presentation, I just wanted to actually share a few of the key lessons learned from the pellet experiences thus far. We've had a number of countries, as I mentioned, conduct either small pilots or just introductions at a very closely monitored level, so that they can really kind of facilitate learnings and really draw out some of the critical components of making sure that the pellet introduction is successful. And so I've noted a few of those here, and many of these are incorporated into the materials that you will see going forward in this presentation in the toolkit. But just wanted to point out a few important ones. So one that's come out of the, actually from the Zimbabwe pellet pilot on acceptability and feasibility, was that practical demonstration of the pellets to caregivers during their education was really important, not only in making sure that they are comfortable, but also allowing them to have those questions, to have the actual demonstration of the opening of pellets monitored by a caregiver or by a healthcare worker, so that that caregiver makes sure that they are doing it in the appropriate way. And then that actually does translate into them being more comfortable with giving the medication, them having a better outcome and fewer challenges. So that's particularly important to include in the training. The use of psychosocial counselors and support groups was really helpful in a number of countries, particularly around allowing caregivers to really have that peer support and discussion amongst other caregivers who were giving pellets to their child. So one of the things that was frequently discussed is kind of troubleshooting which foods or which liquids help children to take the pellets. I think that definitely varies from country to country and from among different contexts, and what food is more appropriate or more palatable. And so I think it was a great avenue and to really facilitate that discussion and have caregivers problem solving with each other and having that support as well. as I mentioned earlier, it's really important that the LPVR formulation that is being prescribed is developmentally appropriate and also clinically reassessed over time. So as they grow, just important to make sure that this is something that's continually looked at, and if there's pill swallowing education for those older children, if that's incorporated into the trainings and the kind of reassessment, that's definitely something that was helpful in making sure that they were the children were on the appropriate formulation. During the planning phase, for countries that are considering rolling out or that are even in their kind of scale-up planning process, a couple of important things to note are just collecting this age disaggregated data and making sure that's cross-checked between facility and national data, and then making sure that follow-up visits occur to ensure appropriate formulation use. And then obviously sharing best practices is great to help other countries learn from existing country experience. So thank you very much. I'll just wrap up and hand it back to Helen.
Great. Thank you, Bethany, for an excellent presentation. It provided us with a lot of context and background information. So just as a reminder, please add your questions for Bethany in the Q&A box for our discussion. Our next presentation is from Ibu Thor, who is a Senior HIV Prevention Technical Advisor on the AIDS-Free Project. And Ibu will be providing a demonstration of the healthcare worker section of the Lopinavir Pellet Toolkit. Ibu, I'll turn it over to you.
Thank you, Helen. Good morning or good afternoon for all the folks. The healthcare worker section of the toolkit provides clinical resources for doctors, nurses, pharmacists, and other service providers involved in prescribing or describing Lopinavir, ritonavir pellet to pediatric patients. The healthcare worker section has 7 sections. The first one about Lopinavir pellet, just information about the Lopinavir pellet. The second section talk about the Lopinavir different formulation. There is a weight dosing tool, how to administer Lopinavir, ritonavir pellet, and frequently asked questions and some case example to help healthcare workers navigate the different situations that they might face in clinical practice, and a very helpful section about information for caregivers. So I will go section by section and just to introduce you to the toolkit. The first topic or section is about Lopinavir, ritonavir pellet. This section of the toolkit provides information on which pediatric patients are eligible to take Lopinavir, ritonavir pellet and why they are recommended for young children. It also, as highlighted in this slide, provides a side-by-side comparison of the solution, pellet and tablet formulation to help determine the appropriate Lopinavir, ritonavir formulation. In this section of the toolkit, you will learn the eligibility criteria. Lopinavir, ritonavir pellet are appropriate for infants and children who weigh 5 kg or more, 3 months of age or older, and are able to swallow pellet with liquid or age-appropriate soft food that do not require chewing. As you will learn in this section, the Lopinavir, ritonavir pellet cannot be chewed, cannot be crushed, or cannot be stirred. This page also refer you to the healthcare worker to additional resources, specifically the fact sheet on Lopinavir, ritonavir pellet, and also the 2016 consolidated guideline on the use of ARV drugs for treating and preventing HIV infection. The next section of the toolkit is the formulation and ART regimen. And the formulation and ART regimen toolkit guides the healthcare worker through a series of questions about the patient age, weight, antiretroviral regimen, and the ability to swallow age-appropriate soft food to determine the most appropriate Lopinavir ritonavir formulation for the patient. For example, if we take the case of a child of age between 3 months to 36 months old, and we input it in the formulation tool, it will ask if the child is on or about to initiate it on non-nucleotide reverse transcriptase inhibitor or PI-based regimen. And if we choose, for example, the PI-based regimen, it will ask, does the child weigh less than 5 kg or more than 5 kilogram? And if we tick equal or more than 5 kilogram, it will ask, is the child able to swallow pellet with soft food, small volume of breast milk or formula? And if the child is able to swallow soft food, the formulation tool will recommend the Lopinavir ritonavir pellet. So, and there's different case scenario. But also there is, at the end of this formulation tool, there is a flow chart that can be downloaded for offline use that walk you through the same process to determine the right formulation. The next session is the weight dosing tool, and the weight dosing tool provides the number of capsules of Lopinavir ritonavir pellet for the morning and evening based on the patient weight, and it keep in mind that the pellets are approved only for use in children 3 months or older. If you use an example, for example, for a child that weighs 6 kilogram and 125 gram that we input in the dosing tool, we get automatically the number of capsules for the morning and the number of capsules for the evening. So the weight dosing tool is also available as an Excel spreadsheet and a printable version for offline use, for people who don't have access to internet or who just want to probably not have to input data but just look at a PDF file with printable PDF file with the band weight and just look at the number of capsules to be administered. We have a section called Administer Lopinavir ritonavir pellet, and this section provides graphic, video, and written instruction to help healthcare worker or caregiver correctly administer Lopinavir ritonavir pellet. And during the usability testing, the healthcare worker liked a lot the poster and the video because I think it's very self-explanatory.
Okay. And then make sure you get your microphones, everyone.
Sorry, I think we have a little bit of technical glitch here. But I was just saying for the section Administer Lopinavir ritonavir pellet, this section provides graphic, video, and written instruction to help healthcare workers or caregiver correctly administer Lopinavir ritonavir pellet. And the video and the poster were very, appreciated by the healthcare worker when we were doing the usability testing in Nigeria. There's also the slide that we can move, at the bottom of the slide, that, the pictorial, that you can move and look at the different steps and how to administer the Lopinavir ritonavir pellet. Moving to the next section, the frequently asked question and answer. This section provides a series of question and answer about Lopinavir ritonavir pellet, their administration and special situation that may occur when giving a dose to a child. And there was a lot of question about in case of the child vomiting, in case of overdose and side effects, and the healthcare worker will be able to find this information in this section. The next section of the toolkit, the case example, provides some potential clinical cases to practice Lopinavir ritonavir prescription based upon various ages, weight, and other patient functional ability. These cases also remind healthcare workers about the importance of assessing the ability of the patient to swallow pellet or tablet during follow-up visit. As the previous speaker has mentioned, there is really a need to assess the ability to swallow pellet or tablet based on the age and weight. And so this case series highlights some of those situations. The information to caregivers. This page delivers a checklist for healthcare workers to share with caregiver on why Lopinavir ritonavir pellets are needed and special situations they may encounter. In this toolkit, we define caregiver as anyone who takes care of a child, such as a parent, another family member, or guardian. It provides also tips for administering Lopinavir ritonavir to a child. There's also a section of additional resources and options. This healthcare worker section lists additional resources like latest research on Lopinavir ritonavir pellet. It contains recent scientific literature and guidelines on Lopinavir ritonavir pellet. It's also an option to download different sections of the toolkit for offline use. So thank you very much. I would like to take this chance just to acknowledge a lot of the people who contributed to this development of the tool, specifically the MOH Nigeria, NACA, USAID, CDC, DOD, the workshop participants, the Clinton Health Access Initiative, UNITAID, Drug for Neglected Disease Initiative, WHO, and definitely the AIDS-free team both in Washington, D.C. and Nigeria. Thank you.
Thank you, Ibu. Thank you, Ibu, for another excellent presentation. And as I said before, please continue to add your questions for Bethany and Ibu in the Q&A box. Our next presentation is from Marilyn Noguera, who is a Senior Technical Advisor at JSI. Marilyn will be providing a demonstration of the Rollout Planning and Management section of the Lopinavir Pellet Toolkit.
Good day, everybody. Good day, everybody. It's a pleasure to be with you all here today. The toolkit has a number of overarching planning sections that I'm going to go through today. And so the page that you see is the home page, and it can be used to navigate all over the toolkit, including the sections that make up the Rollout Planning and Management section. So the Rollout Planning and Management section of the toolkit is intended as a guide for employees of the Ministry of Health, implementing partners, and other key stakeholders involved in rolling out the LPVR pellets nationwide. This section includes information on programmatic decisions, working with stakeholders, planning for initial distribution of LPVR pellets, and eventual management of the supply chain. There are also interactive tools to help calculate the timing of the various processes, quantities of LPVR pellets required, and how to get the product to health facilities. The tools are intended to be used as a reference, a resource to guide the process, and to provide suggestions. You can access the Rollout Planning and Management content by clicking on Explore the Toolkit, which is circled in red, and Rollout Planning and Management in the top left of the page. You can access the Rollout Planning and Management content by clicking on the individual sections further on down this page. So you'll see you've got engaged stakeholders, patient eligibility, rollout strategy, etc. You can access the Rollout Planning Management content also by clicking Explore the Toolkit icons on the bottom of this toolkit homepage, and you'll see the different sections identified pictorially in this way. And following either of the links to the Rollout Planning and Management page provides individual links for each section of content. These content sections can be accessed by clicking on the individual links. The order of these links generally follows the sequence of recommended actions to secure successful rollout of LPVR pallets. The first step is to engage relevant stakeholders. These content sections can also be accessed at the bottom of this page through red buttons, such as the one for Engage Stakeholders on the main rollout page. Once these individual pages, the red buttons are available to scroll from one section to the next. Okay, that's enough on the navigation. We're going to talk a little bit about the specific content of the different sections now. So the first page of rollout content focuses on engaging stakeholders in order to ensure commitment and involvement through the new product introduction process. Like other individual content pages, this page includes paragraphs explaining the recommended task and providing useful content. This content includes recommendations as text as well as links to downloadable tools and recommended external resources. Each content section page generally follows this layout, including the red buttons at the bottom to navigate between sections. You can also navigate between sections by clicking the back button on your browser to return to the Rollout Contents page. On each content page, you can also download a PDF of the page for offline viewing by clicking the red button in the paragraph which describes the task. For example, ideas on education of decision makers and key opinion leaders are included in here, as well as the establishment of a dedicated steering committee to plan and coordinate rollout. The next page of content focuses on determining patient eligibility, including which populations of children will be targeted by the initial rollout of LPVR pellets. Some of this was already discussed in previous presentations, but who's priority for pellets, who can be delayed in the transition to pellets, who should not use pellets. And all of this is critical, especially at this time as countries try to begin, but we also know that there are supply constraints in the global supply chain. The next page of content focuses on determining the overall rollout strategy. This includes recommendations on what to make sure to include in the development of this strategy, and key elements are determining the rationale, objective, and strategy for rollout and scale-up, as well as the M&E plan, and of course, the budget for all of the important components. In rollout planning, we look at the timing of individual rollout activities. And we hope you will find the activity planning calendar tool useful. This page includes guidance on how to use the activity planning calendar tool, which is also available to download from this page. The tool is an MX Excel file, which can be downloaded and used to inform local rollout planning activities. This page also includes an overview of this tool and how to use it. You can view screenshots of the activity planning tool and instructions on where to enter required inputs and review outputs. Now looking at the Activity Planning Calendar tool, within the Activity Planning Calendar tool, there are 4 tabs at the bottom, or sheets, which contain the content of the tool. So you can see instructions, activity lead times, activity timeline, and activity descriptions. The purpose of the tool is to determine a target date for completed rollout of LPVR pellets to eligible patients, including required timings of the individual tasks which lead up to completed rollout. The first tab contains detailed instructions on how to navigate and use the tool. The second tab includes data entry for the tool. A target launch date can be added in the first gray cell in the top right of the page. The user must also estimate required timings for each activity listed as you scroll down. This includes, for example, estimating the time required in months to go from having a discussion of adopting a new policy to formally announcing a new policy to introduce LPVR pellets. The tool sums these estimated timings to determine if the target launch date is feasible and suggests a better one if the target is not feasible. Default timings for these tasks are included when you download the tool, but can be manually replaced. Based on data entered in the previous tab, the third tab presents the required timings graphically. This diagram can be used for discussions to map out the rollout planning process. The fourth tab, Activity Descriptions, provides guidance and definitions for the activities laid out on the Activity Lead Times tab, the second tab. This can be a helpful resource if a listed activity is unclear or unfamiliar to you. So as we get back to the rollout contents pages, the next page of content, Procurement Considerations, includes guidance to help program planners and supply chain managers best understand the general requirements and current expected timelines of international procurement of LPVR pellets. There are also points of contact for any specific inquiries that you might have. If we look at quantification, this includes best practices and recommendations related to forecasting future requirements for the new LPVR pellet commodity and supply planning for shipments to make sure that the right quantity of LPVR pellets is procured, shipped, and received at the right time. The quantification section includes a link to download a specialized Excel tool to facilitate this process. So if we look at this forecasting tool, if you follow the link to download the tool, you'll get this MSL file called Pediatric 3-Year Simple ARV Forecasting Tool. Like the Activity Planning Calendar, the tool includes multiple tabs or sheets found along the bottom of the Excel window. Overall, the tool requires inputs about the target population for pediatric ARVs, as well as service provision protocols and current stocks. The tool then uses these inputs to calculate useful outputs about quantities required for procurement in order to ensure that sufficient quantities of commodities are available to treat patients. For best practice, this tool includes all pediatric ARV regimens, including LPVR. Inputs are shaded in pink data entry cells and cover current patient quantities, protocols, regimen switching, available formulations, weight distributions, and current inventories. The user should progress through each tab one after the next to complete the required data. Outputs of the tool include forecasted consumption by formulation over time and recommended quantities for procurement. The next content section, Plan for Healthcare Worker Training, includes guidance to support planning for proper training of healthcare workers to ensure a smooth rollout and uptake of the new commodity. This page includes a list of links to other major components of the toolkit on healthcare worker materials, which have been developed specifically for LPVR pellet introduction. As you can see, the timing of many inputs, such as healthcare worker training, pellet availability, and a plan for who starts with pellets first, needs to be carefully orchestrated. The next content page, Initial Distribution Plan, includes guidance and a downloadable Excel tool to support calculation of initial quantities to provide to health facilities during rollout of the LPVR pellets. Following quantification and initial procurement, once the product is ready to be introduced to facilities, an initial quantity per facility must be calculated, as there is not yet any historical consumption pattern. Following the link to the Initial Distribution Planning tool downloads an MS Excel file called Facility Level Requirements tool. This tool allows you to estimate the initial quantity of LPVR pellets to distribute to health facilities during rollout. This is just to get them started. Like the other tools described, the tool requires some data entry by the user to calculate outputs. On the first tab or sheet, the user enters desired percentages of targeted users to be using LPVR pellets per month. Depending on the inventory control procedures in place at the facilities, the user can then use either of the two sheets to enter the individual facilities and targeted number of patients on an LPVR regimen per facility. The tool then calculates expected consumption per month and recommended initial supply quantities per facility. The next rollout planning content page, Risk Management, includes technical guidance to facilitate a risk management approach to LPVR pellet introduction rollout. During a rollout, numerous potential delays or setbacks can disrupt a successful introduction. This process convenes experts to identify these challenges in advance in order to determine specific actions to avoid or counteract the challenges as they arise. The final content page in the Rollout Planning and Management section focuses on monitoring and evaluation of the rollout for performance management and continuous improvement. This page includes guidance and resources for before, during, and after rollout. Thank you. I'll be happy to take any questions at the end, and I'll hand it back over to Helen Corman.
Thank you, Marilyn, for the very informative. Thank you, Marilyn, for the very informative presentation. We know that it is a lot of information, and we encourage people to peruse the toolkit on their own time also. And as we said, continue to add questions for all the presenters in the Q&A box. Our next presentation is from Awale Dorosimi Ete, who is the Country Director, Chief of Party for AIDS-Free Project in Nigeria. Wale is presenting on behalf of the National HIV/AIDS and STD Control Program at the Federal Ministry of Health of Nigeria and will discuss the progress of Lopinavir pellet rollout in Nigeria. Wale, I'll turn it over to you.
Thank you, Ellen. So I'll be spending the next few minutes to provide updates on the rollout of Lopinavir ritonavir pellets in Nigeria and the lesson learned so far. Just like Ellen mentioned, I'm making this presentation on behalf of the National AIDS and STI Control Program based on the work done in the last 2 years by stakeholders involved in the rollout in Nigeria with technical support by CHAI. So by way of introduction and background, following the revision of the HIV/AIDS treatment guidelines in November 2016, based on the WHO recommendations and other clinical evidences available, a protease inhibitor was recommended as part of first-line regimen for children that are less than 3 years old, with Lopinavir ritonavir recommended as the preferred drug. And when combined as part of a first-line regimen, Lopinavir ritonavir is recommended for such children in combination with abacavir and lamivudine, or in combination with with ridovudine and lamivudine. So before then, the formulations that were available in Nigeria then were the Lopinavir syrup and the tablet, and these came with a number of challenges, some of which Bethany mentioned during our presentation. For example, the Lopinavir syrup had a bitter taste and contained 42% ethanol and 15% propylene glycol. Also needed cold chain management to maintain the integrity of the product, heavy to carry and hard to store, while the tablet, on the other hand, could only be used in children up to 10 kilograms who are able to chew tablets as big as 50 millimeter diameter, could not be chewed or crushed. And so, to overcome some of these challenges, when the pellet was introduced, a number of these challenges were seen to be over, because the pellet was found to be safe and accessible in infants that are greater than or equal to 3 months of age. We also found that the oral pellet provided a better alternative to deliver the preferred first-line ART regimen for children in this age category. And so, as part of effort to introduce the product into the system in Nigeria, in November 2016, a strategy was developed, and this involved the pilot of the introduction in 6 selected facilities with high pediatric client load that were using the syrup at that time. And the strategy also provided allowance for the utilization of the existing stock of the syrup, and planned for scale up to other facilities to be guided by the results from the pilot. And following the introduction into these 6 facilities, there was an assessment visit that was conducted by NASCAP and CHAI to 3 of those facilities, and this was basically to assess the acceptability of the pellets and to find out if there are incidences of adverse effects following the use of the product by the pediatric patients. And a checklist was also developed, which was used with clinicians, pharmacists, and patient caregivers. So during this visit, it was found that a total of pediatric clients, or 40 pediatric clients, have been put on the pellets, and there was no adverse effect reported by any of the clients that were using the product. And therefore, the national program, working with all stakeholders, agreed that there was need for the scale-up to commence by the middle of 2017. However, the scale-up couldn't start because of challenges with availability of the product until January 2018. And at that point, Government of Nigeria, working with CHAI and PEPFAR Nigeria, conducted trainings for focal persons from facilities with high pediatric client load, basically to build their capacity on the use of the Lopinavir ritonavir pellets, and also to sensitize the focal persons on the introduction of the product, and then for them to be able to cascade the training to other healthcare workers who will be managing the product. As at March 2018 last mile distribution that was conducted by the program, a total of 39 ART facilities that already received the Lopinavir ritonavir pellet, and the AMC as of February was about 111 packs, and this has since grown to about 150 as of the last data that was available from PSM projects. Following the introduction, there were a number of lessons that were learned from this, and I think Majorly, it was found that caregivers prefer the pellet to the syrup in children with ages greater than 3 months. It was also found, just like Bethany mentioned in her presentation, that product demonstration by the healthcare workers is critical for the appropriate administration of the products by the caregiver. It was also found that the Lopinavir capsules need to be maintained in the original package to prevent discoloration of the pellet, and also the need for continuous follow-up by the healthcare workers to ensure that the caregivers follow the recommended administration guide. Finally, we found that the Lopinavir pellet dosing is best when it is synchronized to the feeding time of the patient. Other lessons learned from the introduction of the pellet is that it is important to ensure the availability of Lopinavir ritonavir 125 mg tablets. This is to prevent the use of the pellet in older children, which could also disrupt product availability. And I think this further emphasizes the importance of commodity security to assure seamless introduction of the products. We also observed that a child who is used to liquid food may have challenges accepting the pellet, as some of them were observed to spit out the products when it is administered, while some of them also attempted chewing the pellets. A number of challenges that were experienced during the introduction of the pellet. First among these was the low uptake of the pellet post-availability of the product, because when the pellet was introduced and the supply stabilized, the program expected a significant increase in consumption, but we found that this was not the case, and some of the reasons ascribed to this include the attrition from the 0 to 3 years age band by those pediatric clients who were switched to the tablet, and so many of them were moved off the pellet. We also observed lack of adherence to guidelines recommendation by the prescribers and also the dispenser of the product, especially because of concerns around development of resistance to Lopinavir ritonavir, which leaves little options as second line, especially due to the non-availability of Caregivers for use as second line. We also had challenges with poor reporting of the Lopinavir ritonavir pellets in terms of the supply chain management. Oftentimes we found reports coming from the health facilities reporting the pellets under the column that was created for the syrup, and so when you have other facilities that are using both the syrup and the pellet, it was a little difficult to really ascertain what the consumption trend looked like for the pellet separate from the syrup. And so this use of outdated LMIS tools was also a challenge during the introduction. And then in April 2018, stakeholders, including healthcare providers from the facilities, program managers from PEPFAR Nigeria, including CDC, USAID, and DOD, with Federal Ministry of Health and National Agency for the Control of AIDS, participated at the usability testing workshop for the Lopinavir ritonavir toolkit. And the toolkit was demonstrated by all the stakeholders, and feedback received from everyone at the workshop, and the feedback provided during the workshop was used to improve the toolkit to the level it is currently. General feedback from the participants was that the toolkit was well designed, and it was found to be user-friendly with language at the correct level of the target audiences. We also found that the response to the mobile-friendly and online toolkit was really great, especially due to the availability of the offline options and the downloadable tools, which for them was able to overcome some of the challenges that will have occurred due to lack of access to internet. We also got feedback in terms of how the toolkit was found to be relevant and very useful for countries that have never rolled out Lopinavir, ritonavir pellets, and for countries such as like Nigeria, which is still in the process of rolling out the pellets. So some of the recommendations and next steps include the need to increase awareness to health facilities on the availability of the pellets as part of the national recommended commodities to be used for management of pediatrics in Nigeria, and the need for step-down training by IPs and SRs to all the health facilities. Also, there is need for increased advocacy for commitment towards Untitled, as I believe that this will help to ensure that healthcare providers adhere to the guidelines on the use of Lopinavir, ritonavir as part of first-line regimen. Also, the rollout of the revised LMIS tools, which has columns for the pellets to ensure that data that are coming in based on use of Lopinavir, ritonavir can be disaggregated to the applicable dosage form. And then stakeholders in Nigeria are eagerly looking forward to the dissemination of the Lopinavir pellet toolkit to be used by all stakeholders in the country. I want to acknowledge PEPFAR, Trinity Health Access Initiative, and Government of Nigeria for the introduction. Thank you. So I turn it back to Ellen. Thank you.
Thank you, Wale, for providing us with Nigeria's specific information related to the Lopinavir rollout that is happening. And our final presentation is from Janice Lee, who is the project manager for Pediatric HIV, HCV at Drugs for Neglected Diseases Initiative, Dndi. Janice will be presenting on the results from the living study on Lopinavir pellets.
Hi, can you hear me?
Yes.
All right. Thank you. Good morning, good afternoon, good evening, everyone. I would like to start by giving a brief introduction of who Dndi is and what we do. Dndi was founded in 2003 as a non-for-profit research and development organization because of the lack of medicines to treat diseases that affect only the poor and neglected population. Dndi's model has been one which harnesses resources from public institutions, private industry, and philanthropic entities. Today, we have 8 regional offices around the world, working closely with patients and academicians to conduct research to make treatments available. Neglected diseases have been the core of Dndi activities. To name a few: Chagas, sleeping sickness, filarial diseases, pediatric HIV, and hepatitis C. HIV is not a neglected disease per se, but since 90% of the children living with HIV are in sub-Saharan Africa, the lack of incentive for pharmaceutical companies to develop pediatric formulation that's adapted for use in these settings delayed treatment, and that is needed by this population. This is the story of Dndi, who entered into the pediatric HIV space a few years ago, when the only available formulation to treat the youngest children requires refrigeration, tastes very bitter, and contains 40% alcohol, as you have learned. We also tried to address the drug-drug interaction issues with TB-HIV co-infection with evidence provided in 2016 to support super boosting with extra ritonavir. In short, we face a lot of challenges to taste mask Lopinavir ritonavir while making the trying to build the fixed dose combination of 4 ARVs in one, but we're hopeful to deliver this formulation by 2019. So this project of developing the 4-in-1, which is Lopinavir, ritonavir, abacavir, and 3TC is done in partnership with industrial partner CIPLA. This is a snapshot of what the formulation is going to look like, with all the ARVs in one, contained in a capsule that is simple to open and use with water, milk, or food, that is well taste masked, does not require refrigeration, suitable up to the very young infants, is TB treatment compatible and affordable for governments. But what I'm going to talk to you today is this study called the Living Study. While we were working on the formulation development of the 4-in-1, we realized the need to have a protease inhibitor-based regimen to treat the very young children as recommended by the WHO guidelines was huge. The gap was huge. So Dndi started to introduce the Lopinavir ritonavir pellets, which was tentatively approved by the FDA in 2015 in an implementation study called the Living Study, to evaluate the effectiveness and acceptability of the Lopinavir ritonavir pellets plus NRTI tablets under field conditions. So the Living Study design is a single-arm, open-label, prospective, non-randomized, non-comparative, multi-center, multi-country study. Basically, the inclusion criteria is very large. Children from 3 kilos to 25 kilos were accepted at the enrollment. So age is not an inclusion criteria. They can be ARV naive or already started on first-line liquid Lopinavir ritonavir based treatment, or failing the NNRTI based therapy. Or they can also be children who are unable to swallow tablets. So the Living Study design is they are given a backbone of NRTI tablets of either abacavir 3TC or AZT 3TC together with Lopinavir ritonavir pellets. All the sites may not start simultaneously, but the minimum follow-up duration for child is 1 year. So this is the current status of the Living Study. We have started the study in 3 countries, and we have concluded enrollment very recently with 1,001 children enrolled in Kenya, Uganda, and Tanzania. So the study is currently ongoing in these 3 countries to collect at least 48 weeks data in all the children. These results I'm presenting today are interim results, which we have presented in conferences in the past 6 months. In the 610 children we analyzed, 220 completed 12 months follow-up. We can see here that the loss to follow-up and death are very low and not related, and mostly not related to study drugs. The retention rates of these children are also very high, close to 90% at week 24 and week 28. As this is an implementation study, we allowed children who were previously on Lopinavir ritonavir syrup and NNRTI regimen to be enrolled. Note that all these stratified groups showed improvement in their viral load progression from baseline. And I have highlighted at the bottom that overall 50% had viral load less than 400 copies at baseline, and at week 48, 80% achieved this. When we stratified by age, the highest viral load was seen in young children of 5 to 11 months, and consequently significantly decreased in viral load from baseline at week 24 and 48. And this goes across all the age group, as you can see here. So these are quite preliminary data findings, but they show improved viral suppression at week 48 for all the children. This included children who were previously on Lopinavir ritonavir syrup or NNRTI. The final results should be available when all children reach at least 40 weeks in April 2019. So the next thing I want to talk about is a sub-study of the living study, which we have done to assess the acceptance and adherence of the Lopinavir ritonavir pellets. In this sub-study, we have conducted in Kenya in 3 sites. There were 42 in-depth interviews with caregivers, 16 with healthcare providers. We have done 17 observations of pellets administration at home settings and 17 observations at clinic settings of the interactions between the child and the healthcare workers. In these findings, caregivers were found that the pellets are highly acceptable due to the ease of storage. Because of lack of requirement for refrigeration. The packaging is discreet. It has secure closing, no spillage. It's easy to use with administering to liquids, and it tastes good. It lacks the taste of bitterness. And the children accepted the pellets very well if it was given, if the mix was given very quickly, because as time goes, the parents realize that when it's not given very quickly, the pellets can leave a bitter taste on the food. And also we looked at the factors that affect adherence to the pellets. We find that the better acceptability of the new formulation has contributed to the initial adherence of the children, and visible positive outcomes, most notably the child's health when giving the formulation. It's a factor to stimulate maintenance of the adherence, and the easy administration actually empowers the caregivers and stimulate their commitment to continue the treatment. It's a precondition to maintaining the adherence. These are some of the direct experience that we have recorded from the caregivers. From one of them, he said that he has never gotten sick. The changes I've seen is that he has gotten stronger and now he can walk. I have never taken my child to the hospital because he is sick. Another caregiver said, the pellets are easy to administer compared to the other one, the syrup. The syrup required a lot of work because you had to put it in a syringe, measure a particular quantity and give it to the child. But this one does not require a lot of work. So just to conclude, the findings from the living study has contributed to the creation of the healthcare worker training section of this toolkit, with incorporation of real-life experience, better formulations for children, indeed improve adherence and health outcomes. Dndi and CIPLA are committed to deliver the final product, which is the 4-in-1 that contains Abacavir-3TC Lopinavir ritonavir by mid of next year. You can see that it's slightly different from the pellets in the photo here. So it would be a granules, but it would contain all the drugs in one. I've accidentally omitted my acknowledgement slides, but I would like to acknowledge the contributions of our funders, UNITAID, AFD, our industrial partners, CIPLA, study teams, and participating children and caregivers in Kenya, Uganda, and Tanzania. Thank you.
Thank you, Janet. Thank you, Janet. Thank you again to all of our speakers for the wonderful and informative presentations. We will now use the rest of the time for discussion. As I have said before, please type questions for our presenters into the Q&A box, and we will read out the questions. We will try to get to as many questions in the time we have remaining. Any questions that are not answered will be collected, and we will ask the speakers to share their responses, and we will post them on the AIDS-Free website following the webinar. Joining us, as I said in the beginning, for the Q&A session along with the speakers is Sharad Jain, Head of Sales and Access at Cipla Limited, a global pharmaceutical company that manufactures Lopinavir pellets. We are very pleased to have him join. So if you do have questions for Sharad, please do type in questions for him also, along with all of the speakers, on the supply of pellets. Let's go to our first question, and I'll turn it over to Alexandra, who's going to read off our first question.
Thank you, Helen. Our first question, I believe, Wale, was directed at Wale, the speaker, but anyone can answer. It's from Katie. She asks, do you have any viral load suppression data from the children who've been put on pellets thus far, presumably in Nigeria?
Yeah, thank you. I am not aware of that anyway, but I think such data will be managed outside of the supply chain and by the clinical team. I can find out and get back to you on that.
Thank you, Wale. The next question is from Nandita. They ask, in either the guidance for programs or training for healthcare workers, is there any discussion of how to manage NRTI backbone when transitioning from an NNRTI containing regimen to Lopinavir? I think Ibu will take this question.
In the in the toolkit for the transition to non-RTI containing regimen to Lopinavir, it gives you an option to find out if the patient is stable or responding very well or not. And if it's responding very well, the recommendation is just to continue. If now it's not responding, it's where really you have the option to switch to add Lopinavir, ritonavir. But as far as we know, we recommend also the healthcare worker to stick to the national guidelines. I don't know if I replied to your question.
Thank you, Ibu. We're happy to take other questions for any of the speakers. We have a question from Salami. What is the status of pellet supply for children who started pellets in Nigeria? So Wale, if you could speak to that.
Yes, like I mentioned during the presentation, we initially had challenges with the availability of the pellets, but currently we have adequate stock of the dosage form, and from the data I got from PSM project, we have currently about 150 packs consumed monthly nationally.
Do we have other questions?
I think a follow-up question for discussing about the guidance programs or training for healthcare workers on managing NNRTI when transitioning from an NNRTI regimen to Lopinavir. A question for Wale about how this was managed in Nigeria.
Yes, we had a strategy for the introduction of the product. The strategy was to do a pilot just in 6 facilities, where, just like Ibu mentioned, a number of clients who were already on the syrup were maintained on the syrup as long as there were no reasons for them to be switched to the pellet. And that was one of the reasons why the number of pediatrics that were put on the pellet initially was really very low, despite the number of pediatric patients that were eligible to be switched. And once the syrup was no longer available, they were moved onto the pellet. And so for pediatrics that were stable on other regimens that were not containing Lopinavir, ritonavir, they were maintained on that regimen without need for switching them.
Thank you, Wale. I have another follow-up question from Olawale Salami, referring to the 150 packs that you mentioned for facilities who have pellets in Nigeria, asking that the 150 packs is really low considering the needs. So why would you think the consumption is so low?
Based on feedback we got, there were a number of reasons why the consumption still remains very low. One of them is because there is need for training of healthcare providers for them to be able to introduce these pellets to the caregivers. I think that was one of the reasons. And then the second reason was the concern around development of resistance to Lopinavir, ritonavir when used as first line without adequate backup for Rationalization availability to be used as second line for such pediatric patients.
Here's a question for Janice. The new upcoming 4-in-1 formulation is a welcome idea, and this is somebody asking you from Nigeria. However, I hope heat stability is considered in this formulation, especially for resource-limited settings.
Yes, thank you for the question. This is really the main aim of the project that the Dndi has in mind from the beginning, is to have a heat stable, meaning the 4-in-1 would have a storage condition of 30 degrees.
Thank you, Janice. Another question for Wale is a question about the sustainability of the pellets, bearing in mind dwindling donor funding in Africa.
Well, I think the national program will be in the best position to answer this. I think the issue of sustainability for the pellet is not different from sustainability for the availability of other antiretrovirals that are used in Nigeria and in other countries. I think issue of sustainability is becoming something that is the front burner of discussions everywhere, including Nigeria, and hopefully there will be measures that will be put in place to be able to assure availability of these products beyond donor funding. Thank you.
This is a question for Ibu. Will the toolkit be adapted to include other new solid dosage forms as they become available, i.e. the granules?
Yes, I think we would really like to maintain the website, make it functional and up to date. I think everything will depend on resources. If we have the funding necessary, definitely we'll keep the site ongoing and really up to date. Yeah, we hope so. Thanks.
I also want to add to that. So the fund one would be in granule formulation, and we are also looking to develop some of these training materials once we have the drugs tested and used in children, which we are planning in the very near future.
Thank you, Janet. Thank you, Janet. Another question for you. Rachel Golan asks, can some of the tools in the toolkit be used for other current formulations, for example, TLD transition?
I think right now the tool is specifically developed for Lopinavir, ritonavir pellet. We have not considered other formulation. But I think it's something that can be adapted depending on the resources that we'll get.
I think Marilyn also has some thoughts on that.
Right, right. So when I presented the overarching tools, I think guidance such as engaging stakeholders, looking at patient eligibility as you transition from one regimen to another, who to prioritize, developing a rollout strategy, looking at procurement considerations, all of those concepts are absolutely applicable to any regimen transition. I think some of the more specific tools, like the pediatric dosing and things, those are very specific to LPVR, so those would not be applicable. But the logic in some of those could be replicated in Excel or something to develop new tools that are specific to your situation.
Thank you, Marilyn. Another question for Janice. Does Dndi have any updated French IEC materials that can be shared?
I believe the French IEC material is already on the website the last time I looked at it. But if there's further updates that's needed, we're willing to put resources to it.
Thank you, Janice. And something we didn't highlight on this webinar, but there are, as Janice mentioned, several French resources available on the site as well for French speakers to refer to.
Any other questions?
Okay.
I believe we do have one other question here. What if the current stocks of Lopinavir pellets are finished? Do we revert back to the syrup? If so, don't you think this will interfere with the adherence? So Janice or Bethany, I don't know if you can take this question. I can repeat the question. What if the current stocks of Lopinavir pellets are finished? Do we revert back to the syrup?
So, Yeah, so I think this question relates to the lack of supply of pellets, and I would like to defer the question to Sharap of their latest scale-up plan for pellets. Can you take the question, Sharat?
Sure, Janice. Can you hear me?
Yes, we can hear you.
Okay. Thank you, first of all, to inviting me in this seminar. While we are expecting an FDA approval, we have already submitted a fresh dossier to FDA with the increased batch size and as well as the use of new equipment to increase capacity. We are hoping to have this approval soon. Actually, it is expected in the month of June. We will be able to increase our capacities from the current to 2.5 times, which means that there will be sufficient availability of the Lopinavir ritonavir pellets effective from the month of August, because we will need 1 month in July to complete the validation once we have the approval from FDA. Thank you.
Thank you, Sharad. That's very exciting to hear. For a question for Janice, what is your advice for caregivers who struggle to administer Lopinavir pellets? Eswatini has seen very minimal caregiver satisfaction in a very small pilot program. So what is your advice?
From our experience in the interviews we have conducted, there were many trial and errors that the caregiver has to go through, and so I think one of the ways to support is emphasizing healthcare worker training and the support that can be given from the healthcare worker to the parents, and over time we find that it's the caregiver who will find a way to administer the pellets, and once they find this way, because every child is different, and the timings, the setting, and how they give the administration would also differ, and I guess the best advice is to make to ensure a follow-up by the healthcare workers with the mothers to explore options of administration together, and most of the caregivers we have interviews, they manage to come up with some plans of how they do it.
Just to follow up on Janice's sorry, I just wanted to comment, follow on to Janice's response, definitely echo what Janice said, and from my observations in country settings where pellets are actually being rolled out, just making note that the use of the support groups was really beneficial in overcoming those administration challenges, and often we found that caregivers really had some great suggestions on, what the preferences are for administration and what their child best took the pellets with. And I would also just say, again, as Janice mentioned, having that demonstration and observing the caregiver actually giving the pellets helped to kind of problem solve some of the issues with administration. So, for example, maybe they're giving too many pellet capsules at one time, and that could be addressed, or potentially it's just changing up some of the kind of administration process. So I definitely agree with Janice that I think these are things that can be worked out with careful monitoring.
Great. And following up on the question concerning the supply, somebody said that the reason they were asking the question concerning supply is that they're currently in Kenya and they have challenges with the reliable supply of pellets. And also in Nigeria, in terms of some of the clinics there, they also had challenges in terms of supply of the pellets also. So I think that is one of the reasons that the question was asked in terms of the supply of pellets. So I know, Bethany, you now have you're able to speak. So I don't know if you want to speak to this now.
Yeah, apologies. I was frozen on mute earlier. But yeah, so what I would suggest there, you know, in addition to the comments already made about, you know, the future supply, I would just stress that it's really important to have proactive planning, that the ministries and the quantification units have actually then, so the APWG that really is kind of coordinating the global visibility into the orders across countries and working with CIPLA on that as well, as you know, looking at supply and matching that with demand. So they've actually recommended that countries proactively share their forecasts for pellets. And have that dialogue to really kind of think through the supply and availability and what the country needs are. You know, that said, I do think that for larger countries where there's, you know, greater demand, it will be important to have a backup of, you know, either syrup or a tablet formulation, depending on what's appropriate for, you know, those countries for the meantime until this supply situation has stabilized, you know, simply because of those larger volumes. So if there are questions regarding, you know, patients that have either been already put onto pellets or anything related to the supply, I would really encourage you to reach out directly to the APWG. They're definitely the most up-to-date with just visibility into the broader supply and the broader orders coming in, and we'll be able to work and address the questions that you have regarding supply.
Thank you. And I think Marilyn is going to add something also. Thank you.
Yeah, and I just wanted to add at the country level, as this gets rolled out, it's really crucial that the steering committee look on a monthly basis really at monitoring the supply pipeline. So what is really happening with uptake and what is really happening with incoming supplies of the product into the country, because there might be a need to actually slow down rollout if the supply environment is uncertain. So, you know, if you're monitoring on a monthly basis, then you have the opportunity to adjust and make some changes in your rollout plan. If you make a plan and then just start implementing it without monitoring, then you get into supply issues. So that's just what I wanted to add. So, you know, having your supply chain people at the table and getting them to share that data and having, you know, the clinicians and the leaders of this initiative really looking at all of these aspects is critical.
Thank you, Marilyn. This is a question for all presenters. Will there be anything at AIDS 2018 conference regarding Lopinavir pellets?
It's Janice here. I can just say that I think we have an oral presentation at the AIDS conference, and there is a pediatric satellite that we're coordinating with 8-Path ASLM CHI for diagnosis and treatment of children on Monday the 23rd from 12:30 to 2:30. So you're all welcome.
Great. I'm sure you will have good attendance and people people will enjoy that. A question for Janice and for Sharad. Does Dndi and CIPLA prepare a 4-in-1 with double-dose Lopinavir for TB HIV children?
So I'll answer that question. So double dosing is not recommended for children who's co-infected with TB and taking rifampicin. What our study in South Africa has shown is that if we add additional ritonavir to the Lopinavir ritonavir during the TB treatment, that counters the effect, and we know that there are new formulations, for example, ritonavir, 100 milligram powder by AbbVie, and ritonavir tablet that can be used during this period.
Sharad, I don't know if you want to add anything?
Nothing. I think Janice has answered that very well. But yeah, I think as of now, nothing to that. Let's have the pellet commercialized, and then we can look at probabilities for the future if we have sufficient data to support that the double dose can be given and have an age group of patients who will be then eligible for it.
Great. Thank you. And just, I know that CIPLA will also have a booth at IAS, and of course, we will also have cards for the toolkit at IAS, so we'll be letting folks know about the toolkit at IAS also through multiple events. So if there's no further questions, I'm going to turn it over to Alex, who's going to let folks know about how you can hear anything further about the toolkit and the wrap-up of the webinar.
Thank you, Helen. So before we wrap up, we would like to again thank all of the speakers for sharing their time and expertise today. And thank you to all participants for attending and for the rich discussion. In a few days, you will be receiving an email with a link to today's webinar recording. Before we sign off, I want to encourage you all to take a moment to fill out the poll questions you'll see on your screen right now, as the feedback helps us to improve future webinars. So thank you again, and have a great rest of your day.
Thank you to all of the speakers again, and we will talk to you soon.